Hi, my name is Dan Gold. I'm a neuro-ophthalmologist, neuro-otologist at Johns Hopkins, and I'm delighted to be a part of this meeting. Unfortunately, I couldn't be there in person, hopefully in the future. I've been asked to talk about the bedside examination of the ocular, motor, and vestibular systems for the next 30 minutes. Hopefully this will be engaging and enjoyable, lots of videos to hopefully keep everyone awake. Objectives for you. I want you to be more comfortable with the examination of the ocular motor system by the end, as well as the examination of the semicircular canals, but also the utricles. What are my objectives? To keep you awake for the next 30 minutes, but also be so engaging that you don't check Instagram, Twitter, Facebook more than 5 times. 4 times is okay. 5 times is too many in the next 30 minutes, okay? Now that we got that out of the way, how do you examine the ocular motor system? First, we need to realize and recognize that there are a lot of structures. All of the eye movement machinery is living in the brainstem in particular, with lots of fine tuning done by the cerebellum. The range of eye movements is something important to evaluate first on your exam. We've got the ocular motor nucleus of 3 and 4 and 6. What about fixation and gaze holding? If I make a saccade or make a movement out to the right or to the left or up or down, there has to be some mechanism in place to keep my eyes in that position. That's what these gaze holding, these neurointegrators are responsible for, both in the brainstem, the interstitial nucleus of Cajal for vertical and torsional movements, the nucleus prepositus hypoglossi for horizontal movements, in addition to the flocculus and paraflocculus, also known as the tonsil in the cerebellum. These are going to augment the function of those, the gaze holding, the neurointegrators in the brainstem. Saccades, lots of structures responsible for saccades. Horizontal saccades, the PPRF, the paramedian pontine reticular formation for vertical, and for the torsional quick phases, the rostral interstitial medial longitudinal fasciculus. And again, for saccade accuracy and fine tuning, the ocular motor vermis in addition to the fastigial nucleus. What about smooth pursuit and VOR suppression? Again, the flocculus and paraflocculus play a significant role in this as well, but also convergence, optokinetic nystagmus. These are other aspects of the bedside evaluation that we're going to become familiar with by the end here. So there's a lot of overlap between the central and the utricle, semicircular canal, and the ocular motor pathways. So knowledge of this anatomy really helps with localization and trying to figure out what's the most likely etiology. So let's jump right into the exam. So first, you want to know if the eyes move normally in all directions. You want a small fixation target. You also want to know something about their visual function, if they can see the visual target. If they are blind in one or both eyes, that's really going to affect your evaluation as well. Make sure the eyes are steady when they're looking straight ahead, as well as when they're looking in eccentric gaze. This is an example of an abnormal range of movement. This patient has a right 6 nerve palsy. He's got a right abduction paresis. He can't move the right eye all the way to the right due to a weak lateral rectus muscle. And ophthalmoparesis, ophthalmoplegia, it can be anything. It can be supranuclear, as in progressive supranuclear palsy. It can be nuclear. You can affect the nucleus of 3 or 6 or 4. You can affect the fascicle, those fibers that exit the nucleus but are still in the brainstem. It can be the peripheral nerve. It can be the neuromuscular junction, i.e. myasthenia gravis. It could be myopathic or due to affecting the restrictive in the eye muscles, thyroid eye disease. This is going to influence your exam. One big example here is that in this patient who has a right 6 nerve palsy, what if he's also dizzy? And you put on these goggles that only have a camera over the right eye. That's really going to affect your measurements, the video head impulse tests, because again, this eye isn't moving, isn't abducting as it should be. So what about abnormal fixation? So there are examples of nystagmus. In this case, the slow phase is always the culprit. Nystagmus, the slow phase is the phase that's going to bring the eyes, move the eyes away from that fixation, and there's another phase to bring the eyes back. By far the most common variety of nystagmus is jerk. And in here, the most common would be this linear, slow phase velocity, slow phase, fast phase. This is the most common example. This is vestibular nystagmus typically, as opposed to other varieties you might see decreasing velocity waveform, as in something like gaze-evoked nystagmus, or increasing, which is common with infantile nystagmus. There's also pendular nystagmus. It's not a slow phase followed by a fast phase, but rather with pendular, it's a slow phase followed by a slow phase followed by a slow phase that gives it a pendular appearance. This is nystagmus. Blame the slow phase. What about intrusions and oscillations? In this case, the saccade is the problem. The saccade is the movement that brings the eyes, that moves the eyes away from fixation. By far the most common example, square wave jerks, so-called because of their appearance. Their waveform looks like a little square. Here, the patient's looking at the visual target. All of a sudden, there's a little saccade that moves the eyes away from fixation. There, a couple of milliseconds go by, the patient comes back to visual fixation. There's an interval between these saccades. And again, then there's another little saccade away from the visual fixation target. This is by far the most common one. We're not going to go into these other intrusions and oscillations given the time constraints. First step, is it nystagmus or not? Patients with nystagmus or intrusions or oscillations, the main symptom they're going to have is the visual perception of oscillopsia, that the stationary environment is moving, an illusory movement. This is head movement independent typically because, again, the patient's head is still, their eyes are jumping and jiggling, and so is the world, compared to a head movement dependent oscillopsia, which is typical of vestibular loss, which we'll get to next. So this patient, this is the most common example of an intrusion, saccadic intrusion, square wave jerks. Again, the patient's eyes are constantly sort of moving away from that visual fixation target. There's an intersaccadic interval in between each one. These are square wave jerks, okay? In this case, this is a cerebellar ataxia, Friedreich's ataxia, and you can see how prominent they are in this situation. And I will leave it at that. But this is not nystagmus. In this case, the saccade is the culprit. The saccade moves the eyes away from the fixation target. Okay? Not nystagmus. Be able to recognize that because square wave jerks are common, especially with aging, Parkinson's, progressive supranuclear palsy, cerebellar disorders. Okay? So just bringing it all together, nystagmus. Here's an example of jerk nystagmus. There's a slow phase down, fast phase up. This is upbeat jerk nystagmus. In this case, it was due to Wernicke's encephalopathy from thiamine deficiency. This is an example of pendular nystagmus. So slow phase, slow phase, slow phase, looks like a pendulum. This is oculopalatal tremor, which is one of the most common causes for the rare or pendular nystagmus. And let's see an example of another kind of intrusion or an oscillation. This is a back-to-back-to-back saccade, 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 very fast, no intersaccadic interval. And this is an example of ocular flutter, which happened to be post-infectious in this young woman. Okay, so what about gaze holding? Again, I mentioned that if I make a saccade or move my eyes over to the squirrel outside here to the right, there has to be some mechanism in place to keep the eyes over to the right. And there are gaze holding structures, which I mentioned briefly in the one neuroanatomic figure at the beginning. And so having the patient just simply look at an eccentric target and try to keep their eyes fixed on that target can be helpful in the evaluation. This is a patient with pathologic gaze-evoked nystagmus because her gaze holding machinery in the cerebellum, in her case, or its connections were not working. So what does that look like when gaze holding is not working as it should be working? Here, the patient's looking to the right, and there's right beating nystagmus. Now she looks back, and there's rebound. So it was right beating and right. Now it's left beating when she looks back to center. Now she looks to the left, and there's left beating nystagmus. Now she looks back to center and there's right beating. So that reversal is suggestive of rebound nystagmus, which tells you automatically this is pathologic gaze evoked, not physiologic endpoint nystagmus. Okay? All right, what about saccades? So I like to have a visual target. I usually have the patient make saccades back to my nose. It's just very easy to judge accuracy, to see if the patient's overshooting or undershooting. Taking note of latency, conjugacy, velocity, accuracy. Also having two sort of widely spaced targets can be a little bit easier to appreciate the velocity. Can you actually see the eyes moving, in which case they're probably too slow? But also conjugacy. When the patient's looking back and forth, it's easy to spot an adduction lag from an internuclear ophthalmoplegia, okay? So latency, accuracy, conjugacy, velocity is important. Here's an example of dysmetric saccade. So here the patient overshoots to the right, hypermetria to the right. Here it is in slow motion. Hypermetria, you can see him overshoot the target. And now there's hypometria to the left. And you see it takes him a couple little saccades to get there. 1, 2. 1, 2. So when you see hyper to one side and hypo to the opposite, commonly that's going to implicate the lateral medulla. A Wallenberg syndrome will commonly cause this pattern, although there are other localizations. When you see this, this can be really highly localizing. And if you know something about the saccade circuitry that courses through the brainstem and the cerebellum, again, you can really say, I know exactly where the problem is. And from that, you can usually figure out the etiology. If it happened quickly, it's probably going to be a stroke, for instance. What about smooth pursuit? You want a small visual target, small fixation target, and you're going to move it slowly. If you move it too quickly, the patient's going to need to recruit saccades to keep up, and that's going to give it a saccadic appearance. You really want to isolate the smooth pursuit system with a nice slow movement like this, and all planes, horizontal and vertical. So this is the patient with gaze evoked and rebound nystagmus. And again, you can see when she goes too far to the left, there's left beating. When she goes too far to the right, there's right beating. In the center, you see how choppy it is. It's just saccade, 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 saccade. It's very choppy. She has to substitute saccades because her smooth pursuit system is so impaired, okay? When it's symmetrically saccadic like this, and it is to the right, to the left, it also was up and down, which I don't show you. Think about cerebellar disorders mainly, or think about a basal ganglia problem. Parkinsonism, Parkinson's disease will not cause this degree of saccadic impairment. I'm sorry, smooth pursuit impairment. Progressive supranuclear palsy can cause pretty significant impairment of the pursuit system. But it's all about the company that it keeps. So if a patient has pursuit that looks like this and also gaze evoked nystagmus laterally in addition to rebound, probably that's cerebellar. That's not going to be a basal ganglia disorder. All right, what about VOR suppression? This is a combined eye-head movement, okay? And pursuit and VOR suppression are usually both saccadic or both normal, with an exception, which we'll talk about. And again, this is the same patient with rebound and gaze evoked nystagmus and saccadic pursuit. And here you can see that the VOR suppression is really, really impaired too, just as bad as pursuit. So chop, 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 saccade, saccade, saccade. Again, this is a reflection of her severely impaired pursuit system. All right. So if the pursuit is saccadic, VOR suppression will be just as saccadic as it was in this case, unless there's no VOR to suppress. So if you have an impairment of pursuit and vestibular loss, remember it's VOR suppression. So if there's no VOR to suppress, the pursuit can look really bad, and the VOR suppression, this can actually look much better. When you see that, think about something like CANVAS. CANVAS stands for cerebellar ataxia neuropathy and vestibular areflexia syndrome. In this case, the impaired pursuit is from the cerebellar part of it, and the vestibular loss is from the bilateral vestibular loss. So VOR suppression can look a lot better than pursuit in that situation. All right, what about convergence? So for normal people, usually the near point of convergence, the point at which they see two and one eye kind of drifts outward, should be less than 10 centimeters. You want a small fixation target and move slowly for this as well. This patient has square wave jerks. She has progressive supranuclear palsy, and she experienced binocular horizontal diplopia at near. And in fact, when I perform alternate cover testing, check her ocular alignment at distance, it was normal. Here she's looking at a near target, and you can see that as soon as I uncover an eye, it has to come way in. Uncover the left eye, it has to come way in. Uncover the right eye, it comes way in. So she has a significant exotropia at near, but not at distance, with a very poor convergence, near point of convergence as well. So like I said, it should be less than 10 centimeters. And in this case, it was about 20 centimeters or so, the point at which she saw two and one eye sort of drifted outward. Also, Parkinson's disease is a common cause of convergence insufficiency, in addition to PSP, also head trauma, concussion, also with normal aging, the convergence abilities can degrade to a degree. What about with nystagmus? So this is a patient who had a little bit of upbeat and actually a little bit of ocular flutter too from a pilocytic astrocytoma, status post radiation and surgery years ago. So she had a little bit of nystagmus and some intrusions, but at distance, you don't see much. So here she's looking at distance, and now watch, she's going to look at her thumb. And you can see that it really is going to accentuate that nystagmus and the intrusions, the oscillations, okay? So it's good to see what effect the distance, distant viewing versus near viewing has on acquired nystagmus. Sometimes the patient might have a little bit of gaze evoke. They don't have spontaneous downbeat, but if you have them look at their thumb or look at a near target, you will see them develop downbeat nystagmus. So convergence, it can increase or provoke acquired nystagmus, typically vertical, upbeat or downbeat, or cause it to transition, as in Wernicke's. So a patient with thiamine deficiency and Wernicke's encephalopathy comes into the emergency department and they have spontaneous upbeat nystagmus. You have them view their thumb or a near target, and it'll transition to downbeat nystagmus. So look for that. Also, convergence can damp congenital or infantile nystagmus. And appreciating that pattern can be helpful for some patients if you're not so clear on how long their nystagmus has been present. All right, so this is a full field optokinetic stimulus looking out of a train window. This is going to provoke an optokinetic nystagmus in anybody whose vision is normal. This is a patient who had a complete saccade palsy. So the scenery is causing
and you feel
her
like
eyes
your eyes
to
are
move
getting
to the
stuck
right.
there?
Yeah.
Because her pursuit system works.
Does it all the time.
Okay.
Like if I'm just walking around and then up.
So this patient has a complete saccade palsy, and that scenery, that full field visual stimulation, activates the smooth pursuit system. The eyes go to the right with that scenery, but there should be then a fast phase to the left to bring the eyes back to sort of position reset, and it should continue and create an ongoing optokinetic nystagmus. She has a complete saccade palsy, so she can't generate the fast phases. So no fast phases. If you don't have saccades, then you can't generate optokinetic nystagmus. This is what we do at the bedside. We have an optokinetic flag or an optokinetic tape, and basically this isn't a full field stimulus. Basically, we're looking at the pursuit system as the slow phase and the saccade system as the fast phase. Virtually, I really like this. You can download a free app, the Eye Handbook app, for instance, and I like to put it right up to the camera, and you can elicit a really nice virtual optokinetic nystagmus, giving them sort of a full field stimulus on their computer screen. Also, I like optokinetic flag or the stimulus to look at conjugacy. This patient has a left INO, internuclear ophthalmoplegia, from a left medial longitudinal fasciculus stroke, and you can see this adduction lag. So this is normal, 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 normal in slow motion. Good abducting saccade in the left eye. But now watch the adducting saccade. See how slow that is. Very slow, very slow. So these saccades are not conjugate, and this is a really nice way to bring it out. Optokinetic stimulus allows for rapid assessment of saccades in pursuit, as well as conjugacy, which is really helpful for an INO. All right, you're thinking about checking Instagram, aren't you? So the oculomotor exam, perform it vertically and horizontally, the range of movements and alignment, this is going to influence everything, okay? Fixation, nystagmus or intrusions, do you see anything? Or the eye's nice and quiet? Gaze holding, is it physiologic endpoint or is it pathologic gaze evoke? If you see a lot of nystagmus that doesn't fatigue out to the sides and you see rebound or you see rebound, that is pathologic gaze evoke. Saccades, look at the accuracy, velocity, conjugacy. Pursuit and VOR suppression, if you're unsure about pursuit, confirm with VOR suppression, but make sure that the VOR is working. So also evaluate the vestibulo-ocular reflex. Convergence influences nystagmus. Convergence insufficiency is common in Parkinson's disease and PSP, as well as TBI and concussion. Optokinetic nystagmus, think about it as a quick pursuit saccade screen. It can be really helpful in some circumstances. All right, we're going to move on to the semicircular canals now, okay? So there's a lot here. We're not going to talk about vibration in the interest of time. We're not going to talk about the laboratory evaluation. If you're interested in finding out more about these techniques, how to do them, examples, you can check out my collection through the North American Neuro-Ophthalmology Society. But the semicircular canals, the anterior canal, the posterior canal, the horizontal canal, these are the angular acceleration detectors. These allow me to see a clear image of whatever it is that I'm looking at when my head's in motion. So I can walk down the street and read a street sign clearly in front of me. I can recognize oncoming faces because with every footstep, with every movement of the head, my eyes are constantly adjusting. And that allows the retinas to stay stable. That allows me to see a clear picture of the world. So if the semicircular canals aren't working, if there's disease, oscillopsia is a very common symptom, which I'll show you an example of from a VOR deficit, in addition to dizziness, vertigo, and imbalance. So this is so-called walking oscillopsia. So this is head movement dependent. If you have lost your vestibulo-ocular reflex, you have bilateral vestibular loss, the world is going to bounce and jump because you don't have any VOR to stabilize the eyes, to stabilize your vision. This is a dynamic VOR imbalance, an example of a dynamic VOR imbalance. And this is typically bilateral vestibular loss, sometimes poorly compensated unilateral vestibular loss. And again, compared to head movement independent sitting oscillopsia, which is due to a static VOR imbalance. So if somebody has a vestibular neuritis and has spontaneous nystagmus due to that, then they can also experience a sitting oscillopsia, although typically the vertigo is so severe that they don't see a lot of this oscillopsia, or the oscillopsia rather isn't a big complaint of theirs. They're just so dizzy and vertiginous that really is what's most bothersome. All right, so what about the VVOR, the visually enhanced VOR? This is nice and slow. This is also a combination of smooth pursuit and the vestibulo-ocular reflex. If you have unilateral vestibular loss, the good side can drive the response. So moving the head this slowly is inadequate because the good side can drive the response and because pursuit can compensate for a VOR deficit this slow. So what is a saccadic VVOR? So this, every time you move the head, again, looking through the middle range in particular, because if you go too far, she's got gaze evoked. So chop, 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 see the saccade, saccade, saccade. This is a really saccadic VVOR. And if you see a saccadic VVOR, immediately there have to be, you know that there's two problems wrong. One is that the pursuit system must be impaired, but also there must be a vestibulo-ocular reflex loss. There must be a deficit. There must be a hypofunction in order to have a choppy VVOR. Because if one of them works, then the other can compensate. So if it's choppy, you know immediately that both of these systems, pursuit and VOR, are both impaired. If you see this, think about, which this patient has, think about canvas, cerebellar ataxia, neuropathy, vestibular areflexia syndrome. And this patient just had very severe cerebellar atrophy. So how then do you make sure that the good side can't drive the response? How do you eliminate the pursuit system You can do that with a high velocity, high frequency head impulse test. This is Dr. Z performing a head impulse test, one of the best in the world. And again, when you perform the test this quickly, the good side can't really compensate, pursuit system can't compensate. So you're really doing a good job of isolating the VOR. So what's an abnormal VOR look like? So here, you move the head quickly to the right or to the left, and the eyes are going to go with the head. So the eyes go with the head to the left, and then there's a catch-up saccade. The eyes go with the head to the left, and then there's a catch-up saccade. The eyes go with the head to the right, and now there's a catch-up saccade. So this is a bilaterally abnormal head impulse test, more prominent on the left than on the right. And when you see this, it's typically a peripheral sign, but don't forget about some central or dangerous localizations. Don't forget about the vestibular nucleus, the cerebellar flocculus, as well as the labyrinth. You can have labyrinthine ischemia, that is peripheral, but dangerous peripheral. This is especially if it's unilateral associated with hearing loss, because there's usually cochlear ischemia as well, and acute. This is the rationale for the HINTS Plus exam, which I won't be going into. All right, dynamic visual acuity. This is a really nice way to evaluate the VOR as well. And a normal person really shouldn't lose more than one line. So this patient is able to read the 20/20 line, and then his head is being shaken horizontally and vertically, and he can then read the 20/25 line. So he has lost one line. That's okay. That's well within normal limits. And this is binocular. Okay, so both eyes open. A patient who has this head movement dependent oscillopsia from a bilateral vestibular loss is going to lose a bunch of lines, typically 4 or more lines. If there's significant unilateral vestibular loss, usually 2 to 3 lines. So when you're evaluating the vestibular system, when you're performing provocative maneuvers, we're going to talk about a few now, removing fixation can be particularly helpful. You can do that with Frenzel goggles, which are +20, +30 goggles that magnify the eyes. There's illumination, and the lenses are so thick and so strong that the patient really can't fixate well on anything in particular. So that by removing fixation, you can accentuate vestibular nystagmus. Same thing with video Frenzels. These are really nice because then everybody in the room can see the eyes, and you've really done a good job of removing fixation completely with these infrared goggles. Pen light cover test. If you don't have any of this equipment, you could just simply have the patient cover one eye, blind the other eye with a bright light, and you're partially removing fixation in that way as well. Occlusive fundoscopy, if you're familiar with the ophthalmoscope, same thing, and this is really nice. Have the patient cover one eye, look at the optic nerve with the other, or through the other eye, through the ophthalmoscope. You see the magnification. It makes it very easy to know if there's nystagmus. And this is a really nice technique, but it does require a bit more skill. All right, so what about head shaking? And again, you always want to remove fixation for this. So this is a maneuver that can bring out vestibular asymmetry if any is present. Okay, so this patient has a normal vestibular system, and for that reason, post-head shaking, there's nothing. It does not induce any nystagmus. This is a different story. This patient had a Ramsay-Hunt syndrome causing left-sided vestibulopathy and a left-sided hearing loss 4 months prior. So he initially did have a spontaneous right-beating nystagmus, but there was nothing on his exam on that particular day until you shake his head. And so let's see what happens. So he had no nystagmus initially. You shake the head, and then the slow phase is going to drift toward the paretic left ear, slow phase to the left, fast phase to the right, right beating, head shaking, induced nystagmus. And this is an abnormal response, in this case, abnormal from a unilateral vestibular loss. And it's going to be contralesional when peripheral. The slow phase, again, is going to drift toward the paretic ear. You can see this months later. Sometimes you can see this years later. This can help you to determine what may have happened a while ago, or you can look for different central patterns in the acute setting, which can be very helpful as well. This is an example of something called cross-coupling, where I just shook his head, or our technician just shook his head horizontally, and she has downbeat nystagmus. That is the wrong response. That shouldn't be happening. Some central patterns to look for include a robust head shaking nystagmus without a unilateral vestibular loss. So the last patient's response, but without a vestibular loss, we know that that last patient had a left-sided vestibular loss and had a head shaking-induced right-beating nystagmus, downbeat nystagmus, or upbeat nystagmus. So again, this cross-coupling, you shake the head horizontally and there's a vertical response, or reversal of spontaneous nystagmus. So the patient's in the emergency department, there's right beating spontaneous, you shake the head, now there's left beating. That should concern you. In these situations, you're thinking about the structures of the vestibulocerebellum, the nodulus and uvula, or the flocculus and paraflocculus. Look for these central patterns. All right, summary of semicircular canals in the VOR. So sitting oscillopsia due to spontaneous vestibular nystagmus. Think about the acute vestibular syndrome in this situation. Walking oscillopsia, a very common symptom with significant bilateral vestibular loss. Think about medications that are vestibulotoxic like gentamicin. And basically, why do we do all these provocative maneuvers? If there's no spontaneous nystagmus, we want to provoke it. One thing I didn't talk about is all the positional testing. I suspect that's going to be part of other people's talks, but obviously the Dix-Hallpike, supine roll, bow and lean, all these other kinds of tests can be really helpful as well at the bedside. And we're going to spend a couple minutes on the utricle now, okay? So the otoliths include the utricle and the saccule. These are the linear acceleration detectors, utricle sort of side to side, forward and back, as well as tilting the head, whereas saccule is kind of up and down. Again, we're going to talk a little bit about the utricle. There's not a lot you can do at the bedside to evaluate the saccule. The VEMPs can be very helpful to evaluate the otolith function. We're not going to talk about those, but feel free to check out my collection for more information. The main visual symptom from utricle disease is diplopia due to a skew deviation. So first, what is the physiologic ocular tilt reaction, the OTR? So here's me on my motorcycle. And so this is a great paper that everyone should read. It's about 25 pages of nothing but skew deviation. It took me about 25 tries or so to get through it, but it's a really good paper. So what happens if I'm on my motorcycle and all of a sudden I'm tilting over to the right? So I'm going around a turn to the right. My body tilts to the right. My head tilts to the right. What would be the physiologic response to that? So if the head tilts to the right, it's going to excite the right utricle. The right eye is going to elevate and the left eye is going to depress just a little bit to a minute degree. A little bit of ocular counterroll as well. Top pulls toward the left ear as well. So head is to the right and the eyes are going to rotate, right? So the eyes are trying to keep the top poles as close to gravitational vertical as possible. But typically what's going to happen in normal people is that there's going to be a pretty significant reflexive reorientation of the head back to gravitational vertical. This is the main component of the OTR. Like I said, that little bit of skewing of the eyes is minute. The ocular counterroll is minute. Mainly, it's going to be this reflexive reorientation of the head. So what is a skew and what is the pathologic OTR? So here's the definition. It's a non-paralytic vertical ocular misalignment due to utricle-ocular pathway asymmetry. So what the heck does that mean? So non-paralytic, it just means that the ductions are normal, right? You cover the left eye and you have the patient look up and down fully with the right eye, and there's no motility deficit. There's no paralysis of the eye muscles. Same thing, cover the right eye and the left eye should move up and down fully. It's non-paralytic. Vertical ocular misalignment, this just means that there's a hypertropia. One eye is higher than the other. You can see here that the left eye is higher than the right eye. And due to utricle-ocular motor pathway asymmetry, so that means the pathways that start here in the peripheral utricle and then go to with the eighth cranial nerve and then to the vestibular nucleus and then decussate and ascend via the medial longitudinal fasciculus and then send out projections to the ocular motor or the muscles rather. In addition to sending some additional fibers to the interstitial nucleus of Cajal. So this is the utricle-ocular motor pathway. And so if there's a lesion anywhere, that's going to cause asymmetry and that can create a skew deviation. So ocular alignment, what do? Here's alternate cover testing. So our fellow's covering the left eye. You can see a little bit of a movement inward in the left eye, in the right eye. So this is a horizontal movement. This is not a skew. There's no such thing as a horizontal skew. The take-home point here is that many normal people without diplopia have these very small horizontal movements or phorias. This is not an abnormal test of skew in the HINTS exam. This is a skew. So the right eye comes way up, the left eye comes way down, right eye comes up, left eye comes down. So if you see this vertical ocular misalignment in a patient with dizziness and vertigo, and these patients are almost always going to experience vertical diplopia unless they can't see with one or both eyes, the nystagmus or nystagmus, this is a skew until proven otherwise. All right, so this is always concerning when you see this, and this would be an abnormal test of skew in the HINTS exam. What about fundus torsion? If you have a fundus camera, or if you have the ability to dilate the eyes and look at the back of the eye, you can see that there's a predictable angle made by the fovea. This is the part of the eye that we see our best 20/20 vision, and the optic nerve, and it should be like this. And so you can measure this angle and you can know what it is and you can quantify it and objectively say that there's a problem, as there was in this patient. So this is a young person who had a stroke that affected the left interstitial nucleus of Cajal here. So that's affecting the utricle-ocular pathway up here in the midbrain. And this created what we call an ocular counterroll, where the top pole of the left eye was rotated toward the right ear, and the top pole of the right eye was also rotated toward the right ear, rotated in the same direction. And you can see that this angle is not normal. The right eye is excycloducted and the left eye is incycloducted. So this ocular counterroll is commonly seen with a skew deviation as well as a head tilt. These three findings are referred to as the ocular tilt reaction. And typically there's an SVV tilt as well, which we're going to talk about next. So ocular counterroll and skew, this is a left hyper. With the left hyper, the left eye is incycloducted, as I showed you, and the right eye is excycloducted, but they're rotated in the same direction. Compared to the cycloduction in a left fourth nerve palsy, where the higher eye is excycloducted. Why is that? Because the primary action of the fourth nerve, the superior oblique muscle, is incycloduction. So when it's paretic, as in a fourth nerve palsy, the eye is going to be excycloducted. So the opposite of a skew deviation. So this is a nice way, when you have the tools or the skills, you can nicely distinguish the two, fourth versus skew. You can also measure this subjectively with a double Maddox rod, and I won't get into what that is and how to use that. So the subjective visual vertical, here's the bucket test. And basically the bucket test, the patient's head is going into the bucket. They can only see this black vertical line. The examiner is holding the bucket so that the patient can't get any proprioceptive cues. And the patient's head is placed into the bucket so that they don't get any external visual cues. And basically what we do is ask the patient when they think that this is straight up and down vertical. And then we can look on the back with a weighted string and a protractor to compare to actual earth vertical. This is an easy way, the bucket test is an easy bedside measurement of the SVV, the subjective visual vertical. So what does it mean? So here's a patient with an ocular tilt reaction. He had a big left hyper, so the left eye is too high, you can't see it here. He had a big right head tilt. He had an ocular counterroll, again, top poles of the eyes toward the right lower ear in the same direction as the head tilt. And he also had an SVV tilt. I asked him if he had taken any pictures lately, and he had taken a photo of his door, and this is what he perceived to be earth vertical when he was taking the picture, which is obviously not. This is a consequence of his rightward SVV tilt in the same direction as the ocular counterroll, in the same direction as the right head tilt. If you were to put his head into the bucket, this is what he saw. When the line was tilted way over here to the right, this is what he perceived to be earth vertical. So his perception of earth vertical is tilted way to the right side. And we can measure and quantify that with the bucket test. So think of the SVV as a perceptual consequence of the OTR, abnormal with central etiologies, central utricle pathway lesions, usually in the brainstem, but also acutely with peripheral ones. So vestibular neuritis, for instance, will create an SVV tilt. You can also try the monocular bucket test, and I'll just kind of skip ahead in the interest of time, but this is a subjective way to evaluate whether the higher eye, the hypertropic left eye in this case, is incycloducted. If it was, then you would think about a skew, or if it's excycloducted, in which case you would think about a fourth nerve palsy. And so this can be a helpful way to distinguish. All right, so here's an example. Hopefully that'll bring all this together. So a right utricle pathway lesion, okay? So not the right utricle, but the pathway, the pathway prior to its decussation. This is a lateral medullary syndrome, a Wallenberg syndrome, but you're affecting the right-sided utricle pathway lesion, caudal to its decussation. So the brain perceives, because there's a relative hyperactivity of the left utricle, the brain perceives a left head tilt and tries to get back to earth vertical. So if the patient thinks that the head is tilted to the left, it's going to try to come to the right, back to what it perceives to be center. The problem is that the patient's head was already at center. It was just a false perception of a leftward head movement. And so in an attempt to get back to what it perceives to be earth vertical or center, it's actually going from center to the right side. That's creating the right head tilt. The head is going to go toward the perceived side of the earth vertical, which is to the right in this case. Hopefully that made sense. It's a complicated topic. So summary of the utricle pathways, the pathologic ocular tilt reaction. Think about a utricle-oculomotor pathway lesion, almost always in the brainstem. The ocular tilt reaction, it consists of the triad of a skew, a head tilt, as well as an ocular counterroll. But don't forget about the SVV tilt, which is the perceptual consequence. You can make your own bucket for less than $5 American. If you're interested in doing that, please let me know. I'm happy to send you a nice PDF from the University of Pittsburgh. And we're almost done, almost done. One other point I wanted to make is that if you affect the utricle-oculomotor pathway, either right medulla or left MLF or left INC, this is the same pathway. So over here, technically the OTR is ipsiversive, meaning that everything is tilted toward the side of the lesion. So rightward head tilt with a right-sided lesion. Over here, it's contraversive because the lesion is now on the left side. Those fibers have decussated, and the head tilt is to the right. But this is the same lesion, the same pathway, okay? And the same pattern of OTR. So I think that's an important point to make. Take-home points. The oculomotor exam cannot be overlooked. Checking all classes of eye movements in all planes allows for localization and clues to the etiology. Remove fixation when possible to accentuate vestibular nystagmus. You can do the pen-light cover test. Very easy, cost-effective. With a good history, oculomotor exam, vestibular exam, the diagnosis can almost always be made. Hopefully I've made that point. The lab testing confirms the diagnosis. You really don't need fancy equipment. You need a pen light. You need, your mother-in-law can make an optokinetic flag, which is where mine came from. You can make a bucket. So there are lots of things you can do to be cost-effective and to do a really good, really comprehensive bedside exam on your patients. If you're interested in these videos and many more examples, instructional videos, how to do this, some pathology and different examples of disorders and different etiologies of dizziness and oculomotor disorders, please check out my collection as well through the North American Neuro-Ophthalmology Society. And thank you for your time and attention.